Well, thank you very much. I'm Dr. Kevin Kavanagh, Board Chairman of HealthWatch USA, and would like to talk to you today regarding the perfect storm, COVID-19, tracing the history of ineffective disease policy. In this presentation, I will stress the importance of evidence-based strategies and maintaining an infectious disease infrastructure in the prevention of emerging epidemics. It should be noted that this presentation is the express opinion of myself and not that of HealthWatch USA or the Massachusetts Nurses Association. In 2005, President George Bush stated, "A pandemic is a lot like a forest fire. If caught early, it might be extinguished with limited damage. If allowed to smolder undetected, it can grow to an inferno that spreads quickly beyond our ability to control it." And with these words, he requested $7.1 billion to fund the Pandemic and All Hazards Preparedness Act. This act became law on December 19, 2006. The act created much of the United States infectious disease infrastructure, including the creation of funding of BARDA, which is the Biomedical Advanced Research and Development Authority. The act created key positions in the Department of Health and Human Services for pandemic preparedness and response, and it provided funding for pandemic response supplies in the National Strategic Stockpile. In 2009, the N1H1 pandemic hit the United States. 85 million N95 respirators were distributed from the stockpile. By 2020, only 12 million N95 masks were available, with another 5 million out-of-date masks being present. It was evident that our stockpile was never replenished. It was predicted that we would need at least 3.5 billion masks to address a severe pandemic. Thus, we were dependent upon the free market to supply the rest. But our manufacturing capabilities were largely outsourced to China. To compound the problem, many facilities had a just-in-time 3 to 7 day supply chain. As aptly pointed out by Rosemary Gibson in her book, China RX, we are almost totally dependent on China for our medications and medication precursors. Unfortunately, the same is true for medical supplies and medical devices. One of Ms. Gibson's videos was posted on HealthWatch USA's website, and below it was a comment left by a Chinese pharmaceutical worker which stated, "Okay, the Chinese did not put a gun to U.S. pharma manufacturers' heads and say, move all your production to China. U.S. pharma wanted 3,000% margins and also did not want to pay U.S. workers and technicians. Believe me, none of the savings are passed on to the patient." Around the same time, President Trump placed tariffs on China, which may have preemptively helped us respond to supply chain disruptions. In the spring of 2018, the pandemic response team was disbanded. Their responsibilities were largely assigned to other agencies. When a rumor surfaced about this in 2020, it seemed so unbelievable, it prompted a Snopes investigation. Unfortunately, Snopes verified the rumor as being true. In 2018, before the Presidential Advisory Council for Combating Antibiotic-Resistant Bacteria, HealthWatch USA advocated for the formulation of firm standards and policies for patients, healthcare workers, and their families regarding acquisitions of dangerous pathogens. Currently, only MRSA and C. difficile, which occur in acute care hospitals, are mandatorily reportable on a national or federal basis, and MRSA is only reportable for bloodstream infections. At a minimum, we need routine testing to identify carriers and a mandatory national reporting system for all dangerous pathogens in all types of healthcare facilities. We echoed these concerns in the Journal of Antimicrobial Resistance and Infection Control, along with advocating for a surveillance system and an economic and healthcare safety net for all healthcare workers. We feel the United States needs to go further in our infection control prevention strategies. Currently, the United States focuses on hand hygiene as the primary mechanism to prevent spread of dangerous pathogens. However, in our view, hand hygiene should be regarded as a backup measure, since these pathogens should not be on a healthcare worker's hands in the first place, and if they are, then there's been a breakdown in containment and control. Finally, the CDC has limited statutory authority in addressing pathogens and making change. The CDC can just perform advice and set recommendations. and can only go into a facility when invited. Then in 2019, the CDC recommended enhanced barrier precautions for nursing homes. However, these precautions were a lower standard of care than standard precautions, and they were advocated for use with Candida auris, CRE, MRSA, along with other dangerous pathogens. These precautions did not require isolation of nursing home residents who were carriers of these dangerous pathogens. Resident carriers could wander around the nursing home and engage in normal activities. The healthcare worker was only required to wear gowns, masks, and gloves when engaging resident carriers with activities which are deemed to have a high risk of transmission, but even lower risk activities, such as passing meds, occurred so frequently that we felt there could be a significant risk of exposure. Many have stated, no one could have predicted this pandemic, but nothing could be further from the truth. We had MERS, SARS, and Ebola. And with Ebola, we learned we had shortages of PPE. And there was a book written by Lawrence Wright entitled The End of October, which was published in April of 2020. This book described a severe pathogen emerging out of China, a virus which caused a pandemic and spread to the United States, causing an economic collapse and wreaked havoc and confusion on our healthcare system. It foretold much of what we are going through today. In October of 2019, there was an enactment of a pandemic scenario called Crimson Contagion. This enactment laid out in stark detail repeated cases of confusion in the exercise. Federal agencies jockeyed over who was in charge. State officials and hospitals struggled to figure out what kind of equipment was stockpiled and available. And cities and states went their own way in formulating strategies such as on school closings. Needless to say, this warning went unheeded, and this is what we're currently going through today. The United States also had erosion of its infectious disease infrastructure. According to the OECD, the United States had a progressive decrease over the years in hospital beds per capita. By 2018, we were in the lower third of industrialized nations for hospital beds. The CDC also had a progressive decrease in funding over the years. It was even slated for a reduction in 2020. The CDC had to roll back much of their foreign presence. In 2017, the CDC had approximately 47 staffers in their office in China. By 2020, staffing was reduced to approximately 14, with loss of epidemiologists and other healthcare professionals. We had lost most of our eyes and ears on the ground, and were dependent upon other countries and agencies for much of our information. On January 14, 2020, the WHO tweeted, "The Chinese authorities have found no clear evidence of human-to-human transmission in the novel coronavirus." This probably resulted in a sigh of relief in the general public and also our government. And then the virus appeared in the Pacific Northwest. The CDC and Director Robert Redfield was put in charge. On January 28th, Director Redfield sent the following memo. While we believe the 2019 novel coronavirus poses a very serious public health threat, the virus is not spreading in the U.S. at this time, and the CDC believes the immediate health risk from the 2019 novel coronavirus to the general public is low. A day later, on January 29th, Peter Navarro, a top White House advisor, sent a memo to the White House warning that the novel coronavirus was highly infectious and could cause a severe economic disruption in the United States, and that the virus had an R0 of between 3 to 5, similar to the bubonic plague, polio, and smallpox. An R0 is the infectivity of a pathogen, where an R0 of 3 means that on average every person with the disease will spread it to 3 other people. With the virus having an R0 of between 3 to 5, it is hard to believe that person-to-person spread had not been detected earlier. President Trump responded by placing a travel ban on travelers from China. Initially, he was widely criticized for this, with many stating it would not be effective. However, in April, when CNN reported on Taiwan's response, Taiwan's success was partially attributed to enacting early travel bans on China. Most public healthcare experts agree the initial travel ban was beneficial in buying time to gear up for the epidemic. A ban was not placed on Europe until much later, allowing the virus to enter the northeastern United States, causing havoc on New York City and Boston. Ultimately, the time bought by these travel bans was largely squandered. On February 26, 2020, the CDC held a telebriefing which warned of severe disruptions to our communities and way of life. Communities needed to plan for school closings and even teleschooling. This stark warning caused the stock market to crash, and the White House immediately walked back the statements, causing the warning to go largely unheeded. Testing was another problem. Initially, the federal government decided not to use the WHO test, which was developed in Germany, and have the CDC develop the test to be used in the United States. Unfortunately, the CDC test was found to be defective and had to be recalled, resulting in a shortage of testing with very narrow testing criteria. We did not have enough tests to detect community spread, and as a result, the virus spread undetected throughout the United States. The CDC then became noticeably absent from the podium of presidential briefings, along with being absent from news conferences. It was felt this may have been due to the alarm they sounded regarding the pandemic and the missteps with testing. However, the CDC was needed. They are the one agency which has boots on the ground and first-hand knowledge of how to handle pandemics. Presently, even the White House's coronavirus task force has been largely sidelined and appears to be somewhat silenced. Because of the need for increased testing, the FDA responded by allowing marketing of antibody tests without review and isolation. Hopes of opening the economy were placed on the identification of immune individuals. Hundreds of different tests flooded the market. However, Europe and the CDC found these tests to be not accurate, having a very high false positive rate, and less than half of the positive antibody test results were correct. The FDA reversed course 50 days after initial approval and tightened standards. Currently, we still have a myriad of tests, many of which require specific reagents and supplies, which greatly increases the complexity of the supply chain. There was spreading of misinformation that masks and social distancing were not necessary, despite the United States' past experience with the 1918 Spanish flu pandemic. As can be seen in this diagram, in 1918, Philadelphia had a large spike in the number of daily deaths compared to the flat curve of St. Louis. St. Louis acted early and implemented closures and social distancing. Philadelphia did not. In addition, the president gave confusing messages that seemed to support demonstrators who were protesting state closures, while some were banishing semi-automatic weapons. The president tweeted, "Liberate Minnesota, liberate Michigan, and liberate Virginia," and that your Second Amendment rights were under siege. And early on, a Fox News commentator even called the epidemic a hoax. False information was spreading widely on the internet. A study by Carnegie Mellon University found that nearly half of the accounts tweeting about the coronavirus were likely bots. These bots seemed to follow the playbooks of the propaganda machines of Russian and Chinese governments. This was confirmed by Reuters, which described a European Union document detailing how a Russian disinformation campaign was pushing online fake news. The fake news was in multiple languages, making it harder for the EU to communicate its pandemic response. And some of this news was just bizarre. There were reports that Bill and Melinda Gates Foundation created the virus, that Pope Francis had tested positive, and that Vice President Mike Pence was telling infected individuals to go to the police, and that the coronavirus was a Chinese bioweapon. There was also the false assumption that the virus respected geographic boundaries. It was felt that large outbreaks could only happen in the Northeast or major cities. But look at what happened in Kentucky. Early on, the major outbreak in the state was in rural Warren County and surrounding rural counties. During a COVID-19 Senate hearing, Dr. Fauci stated, "We cannot focus on those areas of the country having a surge. It places the entire country at risk." A reactive regional strategy may quell an outbreak, but we need a proactive, uniform national strategy to prevent outbreaks and viral spread. There was also mixed messaging regarding the use of masks. On February 29th, the Surgeon General tweeted to the public, "Stop buying masks," that masks were not effective in preventing the general public from catching the virus, and that they were needed for healthcare workers. Granted, the United States had a severe mask shortage. At one point, the CDC even recommended that as a last resort, one could wear a bandana. Initially, N95 masks were not recommended for all COVID-19 patient encounters, and the risk to the healthcare worker of not wearing an N95 mask was downplayed. The CDC reversed their stance regarding the public wearing masks when it was realized that between 40 to 45% of infections were asymptomatic or pre-symptomatic, and that these carriers caused a substantial amount, possibly up to 50%, of the transmissions. Thus, the mask is not so much to protect the wearer, but if the wearer is an unknown carrier, it will help to protect others. However, this policy was not being promoted by all. The president felt the wearing of masks was voluntary. In June, the president even toured a manufacturing plant, which manufactured swabs used for COVID-19 testing. He did not wear a mask. A semi-sterile environment was required, with employees wearing masks, coats, booties, and hairnets. Thus, a day's worth of this valuable production had to be discarded. This was not a Democrat versus Republican issue. The vast majority of Republican governors encouraged the public to wear masks. Governor Charlie Baker of Massachusetts and Governor Larry Hogan of Maryland even enacted statewide mandates for the public to wear masks. Senator McConnell, the Republican majority leader of the Senate, and Vice President Pence, both Republicans, both encouraged the public to wear masks. And by the end of June, Fox and Friends co-host Steve Doocy even encouraged the president to wear a mask. The CDC advocated for mask wearing. At first, they stated, parishioners should wear masks at church while singing, but after weeks of negotiating with the White House, they had to walk this back. The CDC then urged masks to be worn at large gatherings such as protests and political events. But because of mixed messaging, this advice had reduced impact. And then there was our supply chain. Our supply chain was nothing short of a disaster. Initially, President Trump stated he was not a shipping clerk, and that governors needed to be in charge of procuring PPE, supplies, and tests. This resulted in governors bidding against each other and against the federal government, which caused huge increases in prices, much like on eBay. The LA Times reported the federal government was seizing supplies from hospitals. Robert Kraft, owner of the New England Patriots, bought for $2 million 1.3 million masks from China, had them flown to New York City for transport up to Massachusetts. Upon arrival in the United States, the federal government seized the shipment. Governor Larry Hogan of Maryland bought COVID-19 testing kits from South Korea and had them flown to Maryland, where the Maryland National Guard took them to an undisclosed location, presumably to prevent them from being seized by the federal government. This was not a Republican versus Democrat issue. Governor Larry Hogan of Maryland, Governor Charlie Baker of Massachusetts are both Republican. This was just mass chaos, and the results can be seen here. On January 21st, the United States had one confirmed case, and we had approximately 4% unemployment. South Korea was the same. One confirmed case, 4% unemployment. By May 11th, we had over 80,000 deaths with 15% unemployment. South Korea had 256 deaths and 4% unemployment. By June 19th, we had almost 120,000 deaths. South Korea had under 300. Now, a few states did have success stories. Governor Cuomo in New York State were able to drive down cases to one of the lowest infection rates in the nation. He implemented shutdowns, mandatory mask requirements, and social distancing. Governor Cuomo also enacted several innovative strategies by mandating a disjointed hospital system operated by a myriad of corporations to work together. They had to share staff, to share supplies, and they had to share ventilators. Some facilities, especially nursing homes, were even designated as COVID-19 only facilities. There were, however, some missteps, with patients who had COVID-19 being discharged to nursing homes, but this was rapidly stopped. By the end of June, the United States had over 40,000 cases per day compared to the European Union, which has less than 5,000 cases per day. And the EU has a larger population than the United States. Currently, the United States has over 50,000 cases per day. And in June, the United States had political rallies and numerous demonstrations. Shown here is an indoor rally for President Trump, which was held in Oklahoma on June 20th, 2020. The event was indoors. Participants were very close together. Few participants wore masks, and it was held at a time when coronavirus cases were skyrocketing in Oklahoma. One of the bright spots in the United States was our vaccine policy. It has been largely on target. There are over 100 manufacturers worldwide manufacturing and developing a vaccine. 10 look promising. The United States chose 3 to start manufacturing both the vaccine and associated supplies before phase 3 testing was even completed. So just by chance, if the vaccine was shown to be effective and safe, it could be rapidly distributed to our population. In addition, challenge testing was even being considered to decrease the time it takes to determine vaccine efficacy and to rapidly bring this vaccine to market. However, apparently we have not yet learned our lesson. Just this week, our healthcare workers are starting to run out of PPE. The White House has criticized CDC guidelines on school reopening, which has created mixed messaging. The CDC resisted pressure to change its recommendations and just added references and supporting documentation to their guidance. And then just yesterday we learned that COVID-19 infections are no longer being reported directly to the CDC or NHSN, but instead bypassing the CDC and being reported to the Department of Health and Human Services. So in conclusion, I would like to remind you of an old adage. If we do not change our direction, we are likely to end up where we are headed. Thank you. So we are a little bit ahead of schedule today, and I thought I would answer maybe just one question, and that had to do with hydroxychloroquine. Many have asked me, well, what about hydroxychloroquine and what's going on with that? Why did that turn out to be such a large, and I'll just state a fiasco? Well, it started out simply by hydroxychloroquine having some laboratory studies which said this might be something that would work. And in the beginning of the pandemic, we were desperate for anything. And hydroxychloroquine was used on an emergency basis. Patients were dying. Something had to be tried, and that's what was chosen. But then, unfortunately, it became politicized. And there was messaging that try it. What harm could it do? Messaging, I've heard that it works. Try it. And because of this, it became used extensively throughout the United States. And as study after study came in showing it not to be effective, the politicization increased, and mixed messaging to use it also, in my opinion, appeared to increase. And that resulted in a large number of studies and a large amount of effort being focused on hydroxychloroquine and its safety, the vast majority of which, by the way, has shown it not to be efficacious. And this effort would have been much better spent on other more promising modalities of treatment. And I should also add that the initial cocktail of hydroxychloroquine, that of using that drug plus azithromycin and zinc, didn't make much sense because both hydroxychloroquine and zithromycin causes a prolonged QT interval or added toxicity. And that's what was observed in many of the studies, that if you put the two together in high doses, cardiac toxicity was extremely common in patients. And of course, that toxicity is arrhythmias such as VTAC, which can lead to patient death. So this is not a drug that is one that is currently recommended by the FDA. It's no longer recommended for emergency use. It did, however, take our eye off the ball of more promising therapies such as remdesivir, dexamethasone, anticoagulation, proning, and all sorts of other types of interventions that we've been able to successfully use and lower the death rate. I feel a lot of these interventions were postponed and did not come online as quickly as they could have because of our eye being taken off the ball by this one modality. And I think that was also a very major misstep. I would also add that in one of our positive categories, along with vaccines, is the production of remdesivir. That is very promising in lowering fatality rates. As you know, dexamethasone, which came out of Oxford University, also is lowering fatality rates. So when you see fatality rates are dropping, a lot of this is because the epidemic is not only affecting the younger individuals, but it is also being better treated by medicine. With the interventions we have now, I would expect fatality rates to drop by at least half. And I should add that if our healthcare system gets overrun and we run out of staff, we run out of medications, we run out of remdesivir, then you will see the fatality rates start to skyrocket. And so this is a very dangerous situation which we are currently in because, as you all know, the United States in many areas of our country are peaking still in its first wave. And we are starting to run out of hospital beds and starting to run out of staff. It's much more easier to find a hospital bed and a monitor than it is to find a trained nurse and staff to staff that bed and make it operational. So that is something which I am very, very concerned about. Our speakers for the remainder of this morning represent a variety of different countries, the United States, Netherlands, Spain, and Singapore. And they're going to tell us about their COVID-19 experiences. Shown in this diagram are the 2019 novel coronavirus cases per day, which are in the countries of our various speakers. High bars are worse results, and you can see that 3 countries have absolutely crushed the curve and are doing quite well. And there is one outlier country, which unfortunately is the United States. Our number of coronavirus cases per day is continuing to rapidly increase. And before anybody brings it up, it is not due to increase in testing. This is far outpacing testing, and the number of positive test results are approaching 25%, in one state even 30% of the tests taken. And according to the WHO, you want to have that figure below 5%. So this is a very unfortunate circumstance that we're currently in, and it's one which I feel is due to lack of federal strategy and mixed messaging. And so with all of the politicization and mixed messaging which is present in the United States, I feel that we definitely need independent, confirmatory, outside expert voices. And hopefully doubters will begin to realize that this virus is a very serious public health threat. And many countries have formulated national strategies to combat this. The United States needs to do the same.